Cool. Thanks everyone for tuning in. This should probably be 20 minutes to half an hour. It's a talk that I'd just been pulling together anyway in a very sort of slimmed down version, but I've added in a little bit more technical information for this morning's audience, so it might be closer to half an hour. But yeah, I'm Donncha, I'm a psychiatrist. I have a background in physio, which is a little bit why I'm looking at this topic, which combines physical and cognitive measures into one risk factor. It's called Motoric Cognitive Risk, more than a predictor of dementia. So I'm in my first year of my PhD. I started this PhD with the view of trying to find a high risk state for predicting dementia. But as I've seen over the year and a systematic review I've been working on, that it seems to predict more than just dementia. I'm with the Alzheimer's Scotland Dementia Research Centre in Division of Psychiatry, and I work in the NHS as well. Today, I'm going to talk about what is motoric cognitive risk syndrome. I suspect most people won't have heard of it before. I want to just focus a little bit on the clinical relevance. I'm a clinician. I'm only doing this PhD if I thought it would be exploring something that would be clinically relevant in the kind of short to mid-term. I do have some systematic results, review results that I wanted to discuss with you. And because of the audience, I'll maybe spend a bit more time on the methods as well than I would normally of that if it's of interest. But if people are really fed up with that, just tell me to skip through as I'm going along. I'm going to then talk about future avenues for MCR research, motoric cognitive risk research, and then leave you with some take-home points. Take-home points, yeah, it'll be just a minute at the end. So if you want to switch off until then, go for it, and I'll catch you in 29 minutes. Okay, so firstly, why dementia? For me, mainly it was clinical interest. I'm going to probably do old age psychiatry once I finish the PhD. And secondly, it's a massive problem getting bigger, and you can see the projection numbers in millions over the next 30 years. So over the kind of length of our careers, it's going to be just a huge, huge problem in both high and low income countries. And I was surprised by this slide initially. It's from Livingston et al. 2017 Lancet paper, I think it was Lancet paper, showing that about 2/3 of cases of dementia are in low and middle income countries already, so 2020. And you can see in 30 years time, that number, overall number, as well as the proportion is due to increase massively. So dementia is going to be a massive problem in low and middle income countries. I guess I kind of thought, well, people live much longer here, so it's probably more of an issue, but you can see that's not the case. That it's exclusively an issue here. So, and why identify a high risk state? Well, there's no effective drug treatment for dementia. So if we can identify people at high risk, we might be able to address some modifiable risk factors and reduce even a tiny proportion of those likely to go on and develop incidence dementia. And if you can do that, even a tiny percentage, if you can prevent or reduce the incidence, then you're likely to reduce overall morbidity and suffering around the world massively, actually, for a condition like dementia. It'll help people plan for future care, so legal aspects like getting will or power of attorney in place. And it's also really useful in research to be able to identify a cohort that are at a high risk of going on to develop a condition. That's helpful in cohort studies or in drug trials. So what is motoric cognitive risk syndrome, I hear you ask through the medium of Zoom? It's really simply just measuring someone as having slow gait speed, so slow walking speed, and having a subjective cognitive complaint. And I'll come on to what I mean by both of those things, really. And as long as it's in the absence of a significant functional impairment or a dementia. So if you have a dementia and you're a slow walker, and so you've got more than MCR, you don't have MCR, it's more severe than that. So it's really a pre-dementia syndrome of objectively measured slow gait and a subjective cognitive complaint. And for anyone who's in this field or knows about mild cognitive impairment, MCI, which is a much more studied and a longer, it's been around a lot longer, pre-dementia syndrome. You might think, oh, that looks really similar actually, and it is, because all MCI is an objective cognitive complaint plus a subjective cognitive complaint in the absence of functional impairment or dementia. So what MCR does is just replace the objective cognitive measure of MCI with an objective gait measure. And that was really what drew me in with a physio background, thinking, oh, that's quite cool if there's a physical biomarker like that can be used. This is the idea of it here as a prodrome to dementia. So this is MCR, subjective memory complaint and slow gait speed. It's the thinking, this is a hypothetical graph from a recent review on the topic by Semba et al. And it's just showing the idea that MCR is often preclinical, it's picked up because there is no objective cognitive complaint measure. You'll probably score just fine in an MMSE or a MACA. They're two commonly used quick screening tools for dementia or cognitive impairment. And then the idea is that you could progress on, and you may progress through MCI and then on to dementia, or not. You may skip or just go straight to dementia. And I should point out, this graph is just hypothetical. It doesn't mean that everyone with MCI goes on to develop dementia. We know from trajectory work on MCI that lots of people revert back to normal aging, and other people who are normal aging just quickly deteriorate to dementia. But it's just to give you an idea of where we kind of picture MCR in the scheme of things in aging. All right, so on to the clinical relevance of MCR. So it's really a practical thing to measure. All you need is a bit of a stretch of a hallway. Okay, most GP practices, every hospital would have it. A tape measure out a distance, and then a timer, a watch, or a phone. I just need to ask one question: Do you have memory problems? You need to rule out that they don't have dementia or significant functional impairment as well. But you can see it's a really practical thing that can be adapted across countries and cultures. And so in the cohort studies to date, Gait has generally been measured, and I should say that this work has been done, MCR has been looked at in cohort studies and cross-sectional studies, sort of big data studies that have been analysed, rather than in clinical trials just yet, as in clinical trials to treat MCR or prevent it haven't really started just yet. There's one in the clinical trials register at the moment. But so in the cohorts to date, Gait has generally been measured over 2, 4, 6 meters. In the Lothian birth cohort, it's over 4 meters. It needs to be in a straight corridor. You just need to mark it out. It has to be at the usual pace. So you tend not to ask the person to walk their fastest, because it's quite an unnatural thing, especially for older people. It doesn't give you as much rich information as knowing what their usual walking speed is. You might give them, the ideal is to give a bit of space before you start measuring, so a meter or so, to allow the person to accelerate up to their usual pace. Then you measure, and then you stop measuring, and then you give a bit of space at the end, another meter maybe, to allow the person to slow down, and then you capture actually their usual pace rather than acceleration and deceleration. So it's really simple. You might do 2 or 3 tests, get the average. And then this is something I'll labor a small bit, because currently you're defined, and in the MCR literature so far, you're classified as having slow gait speed if you're 1 or more standard deviation below the age and sex matched means for that population. And that's really important, because, so say for example, you are a 72-year-old female in the UK and you have your gait speed measured. That should be getting compared to other females in the UK in that same age bracket, 70 to 74. And if you're 1 standard deviation lower than the mean of that whole group, well, then you have slow gait speed. But if you compare that lady, that 72-year-old in the UK, and you compare her to a 72-year-old in Malawi, say, where I worked, where it's often 40 degrees heat with lots of humidity and there's less to be rushing around for, you might find that this UK lady who's classified as a slow walker isn't a slow walker in Malawi. So it can't be compared across countries, and there's no global references for what is a slow walking speed for 70-year-old across the world just now. And it's important that that's kept like that for now, so that we can look at populations and increase the generalizability within a country, rather than losing it because of so many different factors that could be affecting someone's gait speed. Measuring subjective cognitive complaint has been done lots of different ways in the cohorts using MCR, looking at MCR to date. Often it's a question like that: do you have any trouble remembering currently? How is your memory? Is it good? Is it okay? And then if it's poor, you might get a score, so that will count as having it. Is it worse than 10 years ago? So you can see how quickly that could be asked and got around. And with the kind of pros of that, with the speed of it, with the fact that lots of different cohorts have asked it different ways, but they can all be called subjective cognitive complaint, that's all obviously a pros of the concept. However, there are lots of cons to something as vague as this, and you can argue quite reasonably that it's not measuring the same thing, and it completely varies on what people consider, or what people are if they're, you know, if they've got personality traits that might make them a bit more worried about their memory, a bit more likely to report it, or if there are other reasons why someone might not want to say that their memory is worse than 10 years ago, cultural reasons, for instance. You can see how this subjective cognitive complaint wouldn't capture all those. So lots of pros, lots of cons. But overall, I thought as a clinical tool, it seems quite useful as an adjunct to MCI, which is the one I mentioned earlier, where you get an objective cognitive measure. So that'd be your neuropsych test, a MOCA or an MMSE. With gait speed, it's independent of your education level and your primary language, whereas some of these objective cognitive tests are not. So if you've got a higher education level, you'll generally score better, and you won't, it's less sensitive for you. And if English isn't your first language, you might struggle through it for reasons other than cognitive impairment, whereas gait speed is gait speed. It's suitable to most daily practice settings in both high and low income countries for obvious reasons. There's no training needed to deliver it. It's free, it's quick, it doesn't need any MRI scans, no lumbar punctures. So overall, I think it has a potential for applying at a population level as a screening tool, to then encourage referral on to secondary services for more thorough assessment of cognition or whatever it is that it was being done as a screening tool for. All right, take a wee breather. So I'm going to talk about the results, and again, as I mentioned, there'll be a bit more on the methods for the systematic review. So there's nothing strange or quirky about the methods. So if you've all done a systematic review and are bored to death of it, I'll be talking about this for about 5 minutes, and then I get on to the results. The overall aim of the review was to review the prognostic value of motoric cognitive risk for negative health outcomes. The population, the studies, and the people included were longitudinal cohort studies of community-based older adults over 60s. And the exposure group was an MCR group, so a group with objective slow gait speed and subjective cognitive complaint. And importantly for this review, I didn't just search for MCR as the term, because motor cognitive risk as a term was only coined in 2013, and reviews to date on the topic did, so they narrowed their search term to just 2013 onwards. Whereas I wanted to explore the concept of slow gait and subjective cognitive complaint as a phenotype. So I opened it up to those search terms as well as MCR. And then the comparator group was a group without MCR. And then the outcome, as I mentioned, is any health outcome. So I didn't want to keep it focused just on dementia or cognitive impairment, because a scoping review of the literature that I've been doing early on in the PhD showed that there were MCRs had been shown to be a prognostic indicator in some studies for other health outcomes. If anyone wants to scan that QR code on their phone or whatever, feel free. It'll just bring you to the Prospero website, or you can just either copy down that link, or you can go to Prospero and search motoric cognitive risk. There are a few studies up there, and mine is one of them. This is the Prisma diagram, so you'll just see that. Let me just see, have I gone into more detail here? Search strategy, yeah. So I'll talk about the Prisma diagram in a bit more detail in the search strategy. Okay, so in November, I got 6 known relevant studies that were, and I used these to identify records within AMID, APA Psych Info, Embase, Ovid Medline, CINAHL, and Cochrane. And this is all with the sort of guidance of one of the information specialists at the university. And then I got some search terms, keywords, titles, abstracts, indexing terms of these 6 studies, and then drafted up a search strategy using these terms. And then I added in more search terms as I was searching as I was progressing with the strategy. I validated this search strategy by testing whether it could then identify the 6 known studies that I already had, and they were all identified in Medline. I got a peer to review this. This is the peer-reviewed electronic search strategy checklist. I think it's a 2015 checklist, and it just guides somebody on how they should look through a search strategy in detail to make sure that important factors weren't missed. And then I did a snowball search. I'm not sure how widely used that term is. It's just one I've read a wee bit. It's the sort of forward citation searching and backward citation searching, the hand searching of reference lists. I kind of came up with a semi-automated way of doing that, which saved a lot of time. and used Scopus, so I could put in the sort of 34 or so full text papers that I've finished up my review with and included in the systematic review, and I could put them into Scopus, which automatically searched all of their reference lists, which came to 1,800 or so studies, many of which were the same because they were all coming from similar papers. And then I could deduplicate them all automatically. And what that did was it just left me with, I don't know, 1,000 titles to run through instead of 1,800. And I could just do them as a list instead of having to go to each article and search the reference list of those. That was one I haven't seen anything online about that, but if anyone wants to talk a bit more about that, I'm more than happy to. I then did an update search on PubMed really recently. It started this month to see if there's any new paper. There was one new paper that I was able to include, so that's great. So data extraction, another co-author and myself independently reviewed each title and abstract. There were 1,000 found in the original search, just over 1,000 title and abstracts, and we narrowed that down to sort of 700 after deduplicating, and I think we got about 100 full text articles, and we read through those. Any discrepancies, so we had this bespoke data extraction tool that we used that was iteratively designed, because I've never done this area before. It's not, there aren't that many good systematic reviews on the area to kind of base off. So at the start we found that we were extracting information that wasn't that relevant, wasn't in any of the studies, and likewise there was some important stuff that were in the studies that was getting missed because it wasn't in our tool. So we just added that to the tool, and about halfway through we found a tool that we then used for the rest of the data extraction. We contacted authors when details were unclear. I mean, I didn't want to bore you with the exact detail of what I was extracting in these tools, but it was all the usual, the sort of the study authors, the country, the cohort names, how MCR was measured, how the outcomes were measured, what the prevalence of MCR was, the average age, the gender kind of breakdown. So there's going to be a table in the systematic review, but there's nothing very exciting. What we did want to do is make sure we extracted the adjusted and the unadjusted outcome variables. So that's for anyone who hasn't done it in this area. So say if they're looking at MCR and then 10 years later they follow up to see if you have dementia or not. They should be adjusting in the MCR group, because it'll be comparing the MCR group versus a non-MCR group and see who gets dementia. So they should be adjusting for differences in, if there are significant differences in the amount of people with depression in the MCR group, they should adjust for that to account for our excessive alcohol intake, our current smoking, our diabetes, stroke, arthritis, Parkinson's, any reason that could affect either your gait speed or your cognition should be adjusted for. Some studies reported the adjusted outcome variable, the model, and adjusted and unadjusted, but most just reported on the adjusted. Some collected the outcome variable, so if someone had dementia after 2 years, 5 years, 10 years, and 12 years. What we had to do at the end was to decide which was the most common time point used across the study for that outcome variable, and that was the number we extracted for our meta-analysis, and that allowed us to compare across studies and minimize heterogeneity across the meta-analysis. So quality assessment, we wanted to assess how good each of these papers were. So we had this sort of purpose-designed quality assessment tool that builds on 14 criteria of the Cochrane recommended NIH quality assessment tool for observational cohort and cross-section studies. So that was a really good start. And then we wanted to add in some more to be really thorough. And we added in 15 more criteria from the Strobe guidelines. Strengthening reporting of observational and epidemiological studies, I think. And in the end, we had loads of criteria, and we assessed each study by these 29 criteria. So that was very thorough, but hard to report, obviously. 29 criteria for, 14 studies is what we included in the meta-analysis. So what we did, we both did this independently and then resolved any differences through discussion and a third party. We then wanted to pare that quality assessment down to a more succinct risk of bias tool that we could then report in the paper, and I'll show you that reporting soon. So from the quality assessment tool, we selected the criteria that were probably most relevant to risk of bias in these studies. So these are the 9 domains that we ended up with. So it was bias due to lack of study focus, or bias arising from the cohort and how the cohort was recruited, etc. Bias due to exposure measurement, so that'd be the measurement of MCR if it was measured in a way that was likely to lead to bias. And likewise, the outcome measurement, whatever that outcome was, be it dementia or, and keeping you in suspense for the other outcomes, how that was measured. Missing data is really important, obviously, for this kind of work. Confounding, follow-up, lack of results precision, or results imprecision, and bias due to lack of generalizability. So these are all factors. And then we're nearly there on the methods, and then we get on to the interesting part again. So meta-analysis prep is really, I find how important an area that is. So you want to make sure you're measuring using the right effect measure, because these are all different studies. They haven't been done with each other in mind. So some will report odds ratios, others risk ratios, others hazard ratios. What we found was each outcome tended to have a more commonly reported outcome measure. Luckily, they all use 95% confidence intervals. So we ended up going with those that gave us the most studies. So it did mean excluding a couple of studies that we could not get a hazard ratio, for example, for, and we couldn't calculate it from the data in the paper, and we couldn't get it from the authors themselves. Which is what I'm saying there. Yeah, we contacted lots of authors and got some really good information back, and we could calculate some measures based on what the authors gave us, so raw data, but others we couldn't, so we just had to leave them out of the meta-analysis, but they can still be included in the narrative synthesis. And I was talking about the adjusted models and the unadjusted earlier. We only reported on the most adjusted model results in all of our studies. So it's the most conservative findings likely, and probably the most real world as well. So a little bit on the meta-analysis model. We ended up with a random effect model, and this allowed for the within study sampling error and between study variability due to the word disparate varying study characteristics. And you could argue that you should only really ever use random effect modeling in psychology because of the nature of the studies. Heterogeneity was calculated using the restricted maximum likelihood estimator. I know RevMan and the other software usually uses D'Ursimony and Laird, so that's what a lot of reviews use, but if you can use others such as this one, recent guidance, including from Cochrane itself, talks about using it, and R lets you do that. So I did all my analysis in R rather than in RevMan. Obviously, the tau squared and I squared statistics for heterogeneity were reported. Chose that over Cochrane's Q to better account for, because there were a small number of studies in each of these analyses. The forest plots that you'll see have prediction intervals as well, and they're quite cool in that they illustrate the range for which we can expect the effect of any future studies to fall based on our present evidence in the meta-analysis. And that helps overcome some of the flaws in tau and I squared statistics. All right, so results. So if you've been otherwise engaged for that because you've done lots of them, I'll welcome you back in to mention a bit about the results of the meta-analysis. So this is the overall summary risk of bias plot for the literature, that the 14 meta-analysis studies, sorry, 14 cohorts, but 10 or 11 studies in total. And they're the 9 domains we discussed earlier. So you can see that in general, there wasn't much risk of bias. There was only a couple with some concerns for a risk of bias due to the study focus, due to the cohort used, due to how MCR was measured, or due to how the outcome was measured. So that was all generally pretty good across all the papers. Missing data, however, there were some concerns for most of the studies, and another study with a high risk of bias due to how they managed missing data. For confounding, so generally pretty good, but there were a few studies that didn't manage it well enough and would leave you with a high risk of bias. And similar for follow-up, results precision, and generalizability. So that's a kind of overall summary risk of bias. And then at a more individual level, each paper, each study assessed against the same 9 risk of bias domains, and that's a traffic light plot where you can get an overall glimpse. So domain 1 is column 1 here, and Aguilar-Navarro is one paper that I've used in the meta-analysis. And then down the bottom is the legend explaining again what the domains are. So you can quickly scan across and say, okay, not great, lots of unclear or some concerns. And then a red here is that was biased due to follow-up. So you know that Aguilar-Navarro, there was a risk due to follow-up, but overall it still got good, because I didn't just add these up. I kind of followed the Cochrane handbook guidance on how to do an overall assessment. And it's not just a numbers game, but if overall that there was generally a likelihood not to have too much of a risk, then it can be scored green or good or have a low risk. However, papers such as lowered here has only one red, but it has a red overall. So for this paper, D6, due to confounding, it was so likely that the confounding was going to have a negative impact on the overall results that overall it was scored with a high risk of bias. All right. Okay, so here is the actual results in the forest plots coming up. So this is for dementia. Give you a wee second on that, and I'm kind of presuming that everyone is okay with forest plots, but I have no idea how commonly they are used. I know they're common in stuff that I look at, but yeah, the line here is the reference line. So above 1 makes it more likely that you'll develop dementia, and less than that is less likely. So you can see all the studies were above 1. So if you have MCR, you're more likely to develop dementia. And as these are hazard ratios, we kind of need to know over what the average time is. And for dementia, it's about 5 years was the average follow-up of these studies. The study name, the cohort use, so these US cohorts, and the size of the studies. This was also this is Japan, Canada, and US. So across a few different countries, the sizes, the hazard ratios of each of the studies with their 95, and then the weighting that each study was given. So you might say, oh, why, if this study is 4,000 people, why is it only weighted so low? Yeah, 7.4 instead, whereas this one is much less. So the weighting for these forest plots isn't done just on the size of the study, but it's done on the precision of the effect measure. So Doi et al. Study here, even though it's very big, the effect measure, the confidence intervals are quite wide. So that takes away the weighting compared to the confidence intervals here, which were much narrower. So it's a much more precise result, much more reliable result. Therefore, it's given much more of a weighting. And then overall, the random effect model total is 2.12. So you're over twice as likely to develop dementia if you have MCR by year 5. And the prediction interval here shows where future studies would likely fall. So that's all looks nice and tight. The confidence intervals here of a prediction interval will always be wider than the confidence intervals of what you found, just by the nature of how it's calculated. Heterogeneity results are here, so not too bad, 33.1, chi-squared and p-value. So there you go, that's dementia. Cognitive impairment, similar picture, similar, some of the same cohorts, but it's not the risk of measuring the same cohorts twice for the same outcome. That's because we're looking at a different outcome, so that's okay. But these first 3 are similar, the same cohorts. This one is from China. This is a very recent study. Liu Inchianti is an Italian study, and M. Haas is a Mexican healthy aging study. And you can see here again, the weighting reflects the precision of the results. And you can see heterogeneity is still pretty low. There's none way over here on the left. Okay, falls is another outcome that was shown in lots of different cohorts to be a significant predictor. So EPIDOS was a big French study. HRS, EAS, both US. TASCOG is Tasmanian. Longevity, I think, is US, and Chianti, we mentioned, is Italian. Lilacs, it was done in New Zealand. So there's a non-Maori and a Maori cohort. And the Maori cohort were the only ones where if you had MCR, you were less likely to fall later, but you can see just how wide. This is only a tiny bit of this confidence interval goes way out to here. So it's just a non-significant find. You can't really read anything from that. The numbers are very low, and the 95% confidence intervals are massive and cross 1. So 1 being the reference line here. So the heterogeneity is a bit bigger in falls because of the nature of how these results are falling. But you can still see that this is, and sorry, I should have said the others were hazard ratios so far. It's because they were the ones reported. So this is dementia is a hazard ratio, cognitive impairment was hazard ratio, and this is the relative risk because that's how these studies reported it. So this shows that you're at 38% increased risk of falling if you have MCR than if you don't have MCR. And then mortality was the final outcome that was that I was able to meta-analyze because there was enough studies on it to meta-analyze. And you can see a pretty good going hazard ratio. The total of the random effect model was 1.53. And the heterogeneity is a bit more in this. And mainly US and French studies again. Some funnel plots, just to give you an idea of a publication bias. So on inspection, to me anyway, it looks a little like there's a couple of smaller studies maybe missing here that would have shown something closer to no effect, which would have been a hazard ratio of 1. But the bigger studies look pretty central around the pooled effect measure. And then mortality and sorry, I should say the same for cognitive impairment. So by my eye, dementia and cognitive impairment show possibly some smaller studies weren't published or whatever other reason that they just weren't found there. I did do an Eggers test on these, which was non-significant for all 4 of them, and that makes sense for mortality and falls. But it was almost significant for dementia and cognitive impairment. But in any case, an Eggers test isn't to be relied on really, or there's no real statistical test to be relied on when the number of studies in the outcome is so small if it's less than 10. All right, so we're almost done. Future avenues for MCR research. So in my mind anyway, I think it'd be important to identify reference slow gait cut scores for whatever the population you're working in is. And then that just makes it practical. If someone comes into their GP practice or present to a memory clinic or to a nurse, you can measure their gait speed and you can say, yes, you are slower than your peers. You're 1 standard deviation or more slower than your peers. And then they can be told they have MCR or not. But it'd be useful to identify the best questions, to identify subjective cognitive complaint, to get some gold standard references. And that would help us determine if it's a useful thing to add on someone's MCR status when you're doing a memory clinic referral, for example, from primary care. So I'm still focusing in on dementia and cognitive impairment here, as that's what the kind of most robust findings are, and that's my general interest. But this could be for if there was a general geriatric clinic, say, where you wanted to look at falls risk. And it'd be a case in my mind of, this patient reported with memory loss or confusion, or their partner brought them in because they were more forgetful and they were getting worried. So we've done their bloods, their B12, folate, TFTs, all the usual. We have ruled out depression, we've ordered a CT head scan, and we've measured their gait speed, and they have MCR. And that all those things would factor into whether this person is at a higher risk of, and we've done a MOCA, say, or an MMSV, of a higher risk of going on to develop dementia and would impact on the referral. I'd like to see some comparison work between the different pre-dementia syndromes, such as MCI, MCR, cognitive frailty, physiocognitive decline syndrome. So I could be well and truly barking up the wrong tree with MCR, but that's what we find out over the PhD and thereafter, and whether these other syndromes capture it a bit better. I'd like to see some work on MCR and Parkinson's disease, and specifically depression, personality traits such as neuroticism, as you're more likely to report subjective cognitive complaints and then qualify as having MCR. And then ultimately to see if prevention of MCR are interventions to treat MCR, if that reduces the overall incidence of dementia. So the take-home points: motoric cognitive risk is slow gait speed and subjective cognitive complaint in the absence of functional impairment or dementia. It's a useful prognostic tool for negative health outcomes, and the ones so far in the meta-analysis are cognitive impairment, dementia, falls, and mortality. There are others in the literature, but just not enough studies looking at them to be meta-analyzed. It will be easy, cheap, and quick to incorporate into clinical practice, and it could be a first step for screening at-risk members of the general population. and then referring them on to secondary or tertiary care settings. That's me. Thanks very much. Thanks my funders and my supervisors and the co-authors of the review. Any questions?